Welcome to the Passing on the Torch lecture series. A special welcome to Dr. O.C. Abraham. Thank you, sir, for accepting our invitation. Dr. Susanna, Nitin, and I think Deepak is not able to be here. It is my pleasure this evening to say a few words about Dr. O.C. Abraham, Senior Professor of Medicine and affectionately known as O.C. to all. Dr. O.C. Abraham completed his MBBS from Kottayam Medical College, Kerala, and joined the Christian Medical College, Vellore, for his MD in General Medicine in the year 1986. After completing his post-graduation, he joined as faculty in the Department of Medicine, has been here since then, and that is about 37 years, which is a wonderful long time. During his study leave, he completed his Master's in Public Health from the University of North Carolina, USA, and also completed a fellowship in infectious diseases from the Wayne State University School of Medicine, USA. Dr. O.C. is well known for his clinical acumen and ability to diagnose and manage extremely complex patients. His clinical skills are matched by his ability to bring in the most up-to-date knowledge for patient care. He has successfully transferred his clinical skills and experience to generations of students and doctors. He has inspired his colleagues with his passion for patient care at the bedside and has passed on the sheer joy of practicing good clinical medicine. He never hesitated to appreciate his juniors for their hard work. Dr. O.C. Abraham is a man of brevity with the ability to convey complex topics in a few sentences. As a clinician and teacher, his students have been inspired by his simple gestures like listening to his patients, empathizing with them, and making them feel important and comforted in the midst of their suffering. His thoughtfulness for the less privileged has been an example for everyone. His particular emphasis on rational ordering of investigations and evidence-based practice of medicine has impacted numerous clinicians and students. Dr. O.C. has put in a lot of effort to ensure good and excellent patient care. He wrote the guidelines for HIV treatment in Medicine Unit 1 and has been constantly updating them. He developed the department's approach to fever, diarrhea, respiratory presentations, and CNS presentations in HIV infection and management of ART complications. This was the basis for the various training programs run by Medicine Unit 1 for HIV care. Dr. O.C. was at his best when he taught at the bedside. Being a sound clinician and a teacher par excellence, he served as a role model for countless number of students and colleagues. Dr. O.C. has been a part of many path-breaking research projects and has published widely. In the Department of Medicine, Dr. O.C. has provided exemplary leadership. He always put others first before himself. What stands out is his integrity in his personal and professional life. He always allowed others to grow and supported them through their journey. Dr. O.C. built the Department of Infectious Diseases, joining hands with his mentor, Dr. Dilip Mathai. He developed clinical services, training, and research in HIV care at a time when there was a huge stigma. He was the force behind CMC's antibiotic guidelines. During the COVID-19 pandemic, he was part of the guidelines development team here in our institution. One of his significant contributions to infectious diseases was building a team. Many of our postgraduates have taken up ID because of Dr. O.C. He established the ID department as part of Medicine 1, but when the time came for ID to be an independent department, he chose to stay on in medicine. Dr. O.C. Abraham has been part of and has contributed to several important national committees. He also contributed to the international scientific community through his membership in various societies such as the Association of Physicians of India, the International Clinical Epidemiology Network, Infectious Diseases Society of America, the International Society of Infectious Diseases, and the AIDS Society of India. Honoring his contribution to medicine, he was granted the fellowship by the Royal College of Physicians of London in 2014. For all those of us who know him, he is a gentleman to the core and extremely humble at heart. He has given his best to his master, and God has blessed his efforts and multiplied it. He has truly lived out the motto of our institution, not to be ministered unto, but to minister. For his excellence in teaching and demonstration of the motto of CMC through his life and work, he was given the Best Teacher Award in 2019. It is our privilege this evening to listen to the Passing on the Torch lecture by Dr. O.C. Abraham. Let us put our hands together and welcome him. Welcome, sir. Please come, sir. On behalf of the students, I request Sherin Brito, the General Secretary, to present a small memento to Dr. O.C.
Good evening, friends. Thank you very much, Dr. Solomon, those very kind words of introduction. To me, personally, it's indeed an honor to be here today. At the same time, I have to also acknowledge that this is indeed a humbling experience. You have sat in this auditorium and listened to all those teachers, your seniors whom you admired. And I never thought that one day it will be your turn to stand here in front of this audience. I thought I will briefly sum up my journey through MBBS, my postgraduate training in both medicine and infectious diseases, and my stint here as primarily as a clinician and a teacher. I have titled my presentation, Finding Joy in Medicine. I've divided my talk into three parts. First is about learning medicine. Second is about practicing medicine, and third is about teaching medicine. Learning medicine, the first question you are asked is that, why did I choose to study medicine? To be absolutely honest, I cannot think of a calling or a particular urge that I had to do medicine. My parents were teachers, although my mother never worked after her wedding. Those are my parents. My father is Professor Roy Cherian. He was a chemistry teacher, became the head of the department in his college and retired as the principal of his college. My mother, although she was a teacher, she never worked after she got married and had us. I was the oldest of three siblings. So growing up in a middle-class Christian family in Kerala, parents as teachers, the value of good education was always emphasized. And to parents from middle-class Christian families, they worship professions. You should read this piece by Dr. Abraham Verghese. Although there was no indoctrination or strong brainwashing, we were all encouraged to take up a professional course, and the choice was either medicine or engineering. And I finished my pre-degree equivalent of +2 today in the era before entrance tests were the norm for admission to professional courses. I had fairly decent marks in my pre-degree, so I applied, I got into medicine. So choosing medicine was neither a very carefully planned academic exercise. At the same time, I did not wander into or stumble into medicine also, so it was somewhere in the middle. I joined medicine in 1976 on October 14th, batch of 1976 in Government Medical College, Kottayam. My college is celebrating the Diamond Jubilee this year. That is the batch of 1976. You can see me at the last row. I've circled. And this is a bunch of us 46 years later. As you can see from this picture, people are smiling, dancing. So people have done well after 46 years. I came to CMC in 1985. The date is also significant, 1st April 1985. I joined as a non-PG registrar in Medicine Unit 1. And the sole reason for coming here was this beautiful lady whom I was engaged to marry. So we were married on May 20th that year. She had finished her MBBS examination, was waiting for the results, was soon to begin her internship. So I was a non-PG registrar. So we got married on May 20th, and both of us were allowed exactly 1 week of leave. She was an M3, so Dr. Lilian called her and said that you cannot take more than 1 week, you will not learn anything in medicine. I was in Medicine 1, I was also given 1 week. So we came back. So our honeymoon was in E ward. And we had shared accommodation. We were roommates in hospital annex. Why was that? As a non-PG registrar, I was only eligible for shared accommodation. Sue was an intern. She was also allowed only shared accommodation. But the institution was nice enough to transfer her accommodation and let her be my roommate. So very early, I realized that CMC administration is people-centered. They particular soft corner for young married couple. So that was my first. So on April 1985, if somebody asked me, where would you be 10 years from now? Well, my plan was to let Sue finish her internship. We will go back to Kerala. We will finish our postgraduate training and start work in Kerala somewhere. So I never expected that 38 and a half years later, I will be standing in Scudder Auditorium addressing all of you. As Dr. Solomon said, I belong to the PG batch of 1986 for MD General Medicine. We had 3 medical units in 1986, 6 PGs every year. Medicine 1 was headed by Dr. Benjamin Pulimud. Other consultants in Medicine 1 were Dr. Maman Chandi and Dr. Dilip Mathai. Medicine 2 was headed by Dr. M. Cherian. Other consultants in M2 were Dr. M.S. Sheshadri, Dr. Kurian Thomas, and Dr. A.K. Dayal. And Medicine 3 was headed by Dr. Lily John. Other consultants being Dr. Alka Ganesh, Dr. Jonathan Raju, and Dr. George John. After I finished my MD, I joined Medicine 1. I had 2 brief stints, 1 year in Chapel Hill doing a master's in public health, University of North Carolina at Chapel Hill. That 1 year was eventful because I was alone. Sue and Deepak could not accompany me at that time. I was on a bare minimum scholarship. So I had to learn cooking. So I did both MPH and learned cooking. A lot of misadventures. I particularly remember this episode. I was tempering a vegetable dish, and soon enough, the whole floor of my apartment was covered with mustard seeds. So the rest of the day was spent cleaning up, picking up those mustard seeds. I had to borrow a vacuum cleaner, come and vacuum everything and all. Fellowship in infectious disease was from 1996 to 1998. The 2 people who were primarily instrumental in goading me or encouraging me to do the fellowship in ID are in this picture. This is Dr. Dilip Mathai and Professor P.H. Chandrasekhar. Dr. Chandra, as he is affectionately called, is a CMC alumnus. He belongs to the MBBS batch of 1968. He was the program director for fellowship in infectious diseases at the Wayne State University School of Medicine Division of ID. Dr. Chandra has trained several ID clinicians in India. Without a doubt, he can be considered the godfather of the specialty of ID in India. So not only that, the Detroit Medical Center. So there was Harper Hospital, Hudson Hospital for Women, Detroit Receiving Hospital, the VA, Veterans Affairs Hospital, and also I had a 1-month stint in Henry Ford Hospital for infections associated with solid organ transplantation. The Karmanos Cancer Center in Wayne State had a large BMT program. So for BMT, we didn't have to go anywhere else. But Wayne State did not do so many, few kidney transplant, but not many solid organ transplantation. So for our rotation in transplants, infections associated with solid organ transplant, we had a stint in Henry Ford also. So this is picture with fellow trainees. This is Dr. Jack Sobel, who was the chief of division of ID. He's a friend of CMC. He has been here in CMC in 1989. Dr. Sobel subsequently went on to become the head of medicine and the dean of the School of Medicine. This is Professor Chandrasekhar. We had fellows from all over the globe. We had fellows from Middle East, Syria, Lebanon, Philippines, Czechoslovakia, and these are my batchmates. Dr. Kano, Mithesabia Kano is from Ethiopia. Yunus Musa is from South Africa. He's the head of ID in KwaZulu-Natal University. Me and Alina, and with Dr. Chandrasekhar. This is both of us at a graduation day dinner. So after 1996, I came back to CMC. I continued in Medicine 1 and ID. The joy in learning medicine came primarily from my teachers. I will talk particularly about my teachers here in CMC. So what set them apart? Several characteristics. Of course, they were all master teachers, masters of their domain. More importantly, the other characteristics. First and foremost, there was no passive transfer of knowledge from the teacher to the student. This is Dr. Shastri, JCM Shastri. Sir was the head of nephrology when I was doing my MD. Rounding with Sir was a pleasure. Academic sessions were even better. I have never come across somebody who could explain complex concepts in such simple language. He distilled it to the bare essence, and that's what he conveyed. So it's a true marker of a master, simplifies it. So this is one thing I quote, I think, during my rounds also. So one day on rounds, he said that an injured nephron can respond in one of two ways. It can either proliferate or sclerose. So you think about it. Go back to your room and think about it. Only a master who has mastered the science of nephrology can keep things so simple. Another attribute of the training program and my teachers was uncompromising insistence on excellence, nothing but the best. And medicine too exemplified this principle to the best. This is Dr. M. Cherian and Dr. Seshadri. So the medicine too OPDs were on Mondays and Thursdays, and grand rounds happened on Tuesdays. And those days, the OPD and the admission day was the same. It was concordant. Today we have one OPD and then a non-concordant admission day. So on Monday morning, you had to finish the OPD, finish seeing all the patients in the emergency department. There will be admissions, work them up fully. Problem sheet should be ready, order sheet should be revised, and all the investigation reports should be collected by rounds next morning. So if you didn't do that, well, there was fireworks during rounds. There is a story about Dr. Eugene Stead. Dr. Stead was the chief of medicine at Duke University in North Carolina, arguably one of the foremost medical teachers in North America. So he was a strict disciplinarian, and they were doing morning rounds. And at night, the postgraduate resident had admitted a patient with suspected meningitis, had done the lumbar puncture. Unfortunately, that person had a terrible night. The results were not collected by the time Dr. Stead came for rounds. So he said, what about the CSF reports? So he presented fever, headache, neck stiffness. I did a lumbar puncture. So he said, what about the CSF results? So he said that Dr. Stead, I had a tough night. I couldn't even sit down. Morning, I hadn't had a cup of coffee. I didn't have time for a shower. So Dr. Stead looked at him and then said, Doctor, you're telling me life is hard. I already know that. What about the CSF report? Well, M2 didn't reach that level, but it was not far behind also. Another interesting story was about the salt packets. Those days, patients with hyponatremia, heart failure, anybody who was volume overloaded, they had salt-free diet sent from the dietary and the small packets of salt. I think it was 2 grams or maybe 4 grams. And then it was the duty of the postgraduate registrar and intern to make sure that patient got the adequate amount, what is written in the order sheet. And you can imagine, busy admission day, that's the last thing on your mind. So next morning, Dr. Cherian and Dr. Seshadri will come on rounds. The entire team, Kurian, AK, and patient is still comatose, sodium has not come up, or patient's heart failure symptoms are not improved. And so first thing is that, has the patient taken the adequate amount of salt? Well, yeah, yes. Then there will be a search for salt packets under the pillow, on the bed's cupboard, etc. There was one particular intern, I won't name that person. So they picked out the salt packets. Obviously, the patient had not taken the salt. So he took the packet and said, sir, this is sugar, not salt. So that was the ultimate. Dr. Alka Ganesh was all about clinical reasoning. So this is what she wrote in the souvenir we published during the Diamond Jubilee. I'll read it. Most importantly, the skill of clinical examination and reasoning allows one to confidently steer clear of all except the most necessary tests. Today we have patients admitted. It's all workups. Anybody who has a hemoglobin less than 11 straight away gets an anemia workup. And there are any number of connective tissue disease workup. There are workups. There were no workups during that time. Every investigation you ordered, you had to justify it. It has to be based on your history, physical examination. You made a diagnosis, and therefore I ordered the test. They were also very conscious about the cost. Those days we didn't have automated Coulter counters, so we had to make sure the peripheral smear was reviewed and you had a diagnosis whether it was iron deficiency anemia or hemolytic anemia. Then only you could order further tests. There was no anemia workup. Dr. Dilip Mathai was my guru, my mentor. For everybody from the M1 lineage, Anand, Priscilla, George, Rajiv, Sir was one who nurtured us, guided us, mentored us, found opportunities, and promoted us. For a long time, I was introduced as the vice head of Medicine 1. I used to wonder what that means. Later on in life only, I realized that every visitor who came along, I was the vice head of Medicine 1. I mean, I could not find a terminology like that anywhere, not in my salary slip. It said I was the vice head of Medicine 1. So when the most important thing about Dr. Dilip was that when he was sure that we were ready to stand on our own legs, he let us go ahead on our own, be ourselves, truly a selfless leader, not insistent on making copies of his own image. It's very easy to fall into that trap. So what I do, my team does the same thing. He was very generous in that matter. In fact, we had obvious differences with him. A chief who was not upset about that. In fact, he encouraged us. So we were all, once he was sure that we were ready to stand on our legs, he let us go. So it was not a cookie cutter kind of approach, making clones of yourself. So to sum up PG training in CMC, it was tough, but it occurred in a very collegial, supportive, and safe learning environment. We were allowed to express ourselves, ask questions. Our teachers were, of course, they were master teachers, but they were more than teachers to us. They were our guides, mentors, friends, and philosophers in times of need, well-wishers. Still, they remember your birthdays, wedding anniversaries. They keep in touch. They ask about your children, grandchildren. Of course, the schedule was grueling, but well worth it. It was not all work. We had picnics, we had movie nights, we had barbecue nights, several picnics in M1, games. M1 moved into IDTRC. IDTRC, that's State Bank of India, the top floor. And for once, I think it was first in CMC, Dilip air-conditioned the lecture hall, so we could all go and sit there. One enterprising postgraduate registrar discovered that we had a projector, nice screen, and an air-conditioned room which could seat about 30, 40, 50 people. So we had movie nights in air-conditioned comforts, and there was a nice veranda there. So once we set up a grill there, had a barbecue night, we almost set fire to IDTRC, but thankfully it didn't happen. So it was fun. It was not only work alone. Now moving on to practicing medicine. My stint in Department of Medicine, which was divided between Medicine 1 and ID. 2015, ID became separate, and Medicine 4 subsequently. So 1989, I finished my MD. I joined Medicine 1 and ID. It was Medicine 1 and ID. Till 2013, I was in Medicine 1. I had a short stint in Sultan Qaboos University Hospital in the Department of Infectious Diseases. For about 2.5 years, and came back to Medicine 4 in 2016 when Sam went away on his sabbatical leave, where I remained till I retired on September 15. The most important part of my stint in the Department of Medicine, it was all about people, my colleagues in the department. I was truly privileged to work with such a fantastic group. Medicine grew from 3 to 4 units, 4 to 5 units. Number of postgraduates increased, 6 to 8, 8 to 16. What exemplified this team was teamwork. It was a very well-oiled machinery. Whenever there was a need, they came together, worked seamlessly. absolutely no issues. Many examples. I just cited 3 here. PG training program. When the number of seats increased to 16, and once NEET became the norm for admission to PG courses, we had our own unique set of challenges. So from what was a totally unstructured program, it was like throwing you into the deep end. Residency was all about throwing you into the deep end. You learn to swim. It completely changed. Today, it's a lot of structure, a lot of order. It starts with the baseline assessment of the postgraduates as soon as they join. We have very elaborate orientation program. Sam has made it 1 month now, orientation program. So they are handheld, gently let into the training program. So they are taken through handheld every aspect of the life as a postgraduate registrar. There are a lot of workshops. So there is a lot of hand-holding and support. It would have been possible, but the department working across units as a good team. We had lots of fun organizing 2 jubilees, Golden Jubilee and the Diamond Jubilee. Diamond Jubilee coincided also with the retirement of Dr. Dilip Mathai and Dr. Kurian Thomas. Again, it was great fun organizing that. COVID-19 pandemic, yes. CMC's response was pan-institutional, led by the senior administration. It was the whole hospital came together, the whole institution came together. But then the work on the ground, especially clinical care, the leadership was taken by the departments of medicine, ID, pulmonary medicine, emergency medicine, and critical care. The largest number of feet on the floor, providing leadership. Also, training. Priscilla took the leadership in developing guidelines, but then making sure that this rapidly emerging evidence, it was distilled, it was converted to a form which was digestible for the entire workforce, getting teaching material ready. Again, the Department of Medicine took the leadership along with ID, critical care, etc. Other 2 things which to me was an eye-opener in the Department of Medicine, especially starting with medicine. One was addressing inequities and then also focusing on health and not disease. To elaborate on that, we were told ad nauseum, Dr. Pulimud had a famous statement. We were told that don't think that you're all famous doctors sitting here. That's why people come from far across the country to see you. He said that because they come from Bengal and Nepal and southern Tamil Nadu and other states, that's why you are here. So he flipped the table. The second thing was we were always told that the ability to pay does not determine how the patient is treated. So all the things about addressing the non-medical determinants of health. Even during your problem sheet writing, we had an ICE model and all those things. And Sam always says you should focus on health and not disease. If you look at it, today we have become, we're peddling sickness, okay? We have screening, the cutoff for cholesterol and blood pressure and all our blood sugar is all lowering day by day. We're screening for everything, colonoscopies and mammograms and thyroid scans. And so are we interested in making people sick or making sure that they maintain their health? So lifestyle medicine, it's not lifestyle disease, it's lifestyle medicine. So all these things are eye-openers to me, and then I have tried to put that in my practice also. Some pictures, this is the Diamond Jubilee. You can see many alumni, Dr. Kurian and Dr. Dilip, retirement function also. Recently, farewell from Medicine 1 and Medicine 4. The first case of HIV infection in India was described by Professor Jacob John among commercial sex workers. This was published in 1987 in IJMR. Initially, we started seeing a small trickle of patients. I still remember doing the LP for the first, somebody was already diagnosed with PL-HIV. This patient had suspected cryptococcal meningitis. It was in my final year of my MD. Patient was admitted in isolation ward, a single room. So Dr. Alka came along with me because the LP, she said she will do the LP. I said, no, ma'am, I will do. So I still remember donning all the PPE, primitive, not the sophisticated ones we have now. From head to toe, I was covered in that sweltering heat in isolation ward, doing that LP. LP was successful, patient had cryptococcal meningitis, but then those days, even if you treated pre-ART days, patients will die. So there was a long discussion, should we even do the LP because prognosis is so poor. So from that interesting experience, this slow trickle of patients became a deluge. There was a felt need to provide clinical care for these patients. Also stigma and discrimination. Most institutions, once they diagnose the patient to be a PLHIV, drop them like a hot potato. They didn't have any place to go. So Jacob John sir only started this initiative, helped by Dr. Dilip Mathai from Medicine 1, and Dr. Mary Jacob was the head of dermatology. And Amitinder Kaur, and Anand were the other who helped. I came and joined the team after I finished my ID training and came back. So the ID clinic was a multidisciplinary clinic offering comprehensive care for PLHIV. The philosophy was that they didn't have to wander around the whole hospital, come on another day, come one day. So this was manned by doctors from Medicine 1 and ID, dermatology, OBGYN, pediatrics, psychiatry, ophthalmology, and we had a team of social workers, Joyce, Isaac, Peace, Jacob, and Guna, fantastic social workers, and pharmacists when we started the pharmacy. So it was a full team. A patient didn't have to go unless he broke a bone or needed an appendectomy. He didn't have to go anywhere else, or she didn't have to go anywhere else. It was a very crowded clinic, ran once a week. In the pre-ART era, treatment basically consisted of diagnosing and treating and trying to prevent opportunistic infections. Even if you treated the cryptococcal meningitis, it came back with a vengeance. It was a question of time. PCP came back. Diarrhea, they went home, came back within a few days. Because without ART, there was no treatment. But then we had this whole person care, concept of whole person care or comprehensive care, psychosocial support. We had this fantastic team of social workers. So there were patient groups. They went and looked for places where children affected by HIV could be admitted for that they could complete their education. So many schools around Vellore came up and agreed. There was a microfinance scheme, again helped by an NGO, small loans to this PLHIV so they can buy a cow or start a small business. They went around places in Vellore and found employment opportunities. So a lot of other things happened. So despite, even when ART became available, it was too expensive and there were many problems with the initial ART regimens, which I'll talk in a minute. So this was a very crowded clinic. So patients were becoming sicker, but still they were coming back to us. Even the relatives, family members of deceased patients, they lost their husband, the wife came back to us. So I was wondering, why are they keeping on coming back to us? So that is when I realized that cure is not a prerequisite for healing. So what made them come back? Of course, stigma. Most of places would not see them. Maybe that was one reason. CMC was always willing to see them. So this connection they established with this healthcare team here. They were listened to, people tried to understand them. So this was probably what led to that healing. And maybe a good way of thinking, the pragmatic way of thinking, probably no other places wanted to see them, so they came to CMC. So cure was not a prerequisite for healing. 3 slides on antiretroviral therapy. If there's a miracle in modern day medicine, I will rank antiretroviral therapy right at the top. And I was fortunate to have a ringside view of the advances of ART from the time I went for my fellowship. Wayne State participated in a lot of trials, ACTG, AIDS Clinical Trials Group. All my faculty members were investigators, and we had a large cohort of PLHIV. And they were all enrolled in different trials. So ART was evolving. 1997 was when the first trial of, 96 or 97 was the first trial of triple drug therapy, combination therapy was published in NEJ. So in 1990s, ART looked like this. Up to 20 pills per day, taken at intervals through the day. There were a lot of food restrictions, fluid restrictions, so pill burden, food restriction, fluid restriction, and miserable side effects. So sometimes it was tough to say they became sick with HIV or they become sick with the treatment. Diarrhea, anemia, life-threatening side effects like metabolic acidosis because of nucleoside reverse transcriptase inhibitors. ART has evolved, and today it is 1 pill per day. A combination of drugs, highly potent, single pill per day, so adherence is not an issue, pill burden is not an issue, and safety, hardly any side effects, very few side effects today. Second thing is that with proper treatment early on, so I will emphasize both those things, proper treatment and treatment early on, before they become miserably immunocompromised. People living with HIV can have a near normal life expectancy. It is not normal yet, but again, what was diagnosed with HIV infection was a death sentence maybe 25 years ago. Today, it's no longer. When patients come today, I don't discuss any medical issue. There's no need. I just look at the viral load, CD4 cell count, and we talk about everything except their infection. So it's remarkable. And even more, U is equal to U. If you're on potent antiretroviral therapy and you have fully suppressed viral replication, undetectable plasma viral load, you do not transmit the infection. Sexual transmission, percutaneous, mother to child. So treatment as prevention. Fantastic. So truly a modern day medical miracle, antiretroviral therapy. Other important thing was that these patients keep on coming back to you. They became your friends, almost like your family member. No other place to watch the human condition up close and personal. So the entire gamut of human emotions, hope, fear, happiness, sadness, despair, and we lost patients. A lot of our patients we lost. To me, this was a rejuvenating experience. Sometimes you would wonder, all these things you will go into compassion fatigue. But for me, these shared stories, sometimes we played a small part in these stories. It was a rejuvenating experience. I will briefly tell about 2 couples who are our patients who have been following us for more than 20 years. One was a young man when he came to us in early 2000s. He grew up in the southern Indian states. Because of poverty, he could not complete his school, and his parents sent him to a big metro to be with his uncle who had a job in a big company there. The idea was that he will learn a trade, something like a plumber or an electrician or a mechanic. So he was very good at what he did. He started a small enterprise. He became a mechanic, employing 1 or 2 people. Unfortunately, he picked up HIV infection, passed it on to his wife. When he came to us, he was miserably ill. He had disseminated tuberculosis, wasted, oroesophageal candidiasis, chronic diarrhea due to cryptosporidiosis. Thankfully, all these things we could treat. And ART had just come in, and the extended family chipped in. He was started on nevirapine, zidovudine, and lamivudine. And he went back to his town, which has now become his hometown. He became miserably ill. He developed severe life-threatening anemia, hemoglobin of 3 grams. The town where he worked and lived now had world-class medical facilities. But this gentleman, those days he could only afford a train, now he comes flying. He took the train, literally crawled into our outpatient clinic with severe symptomatic anemia. Thankfully, we can treat that. We changed, transfused him, of course, changed zidovudine to stavudine, continued nevirapine and lamivudine. Few months later, initially we didn't recognize. He came in with severe shortness of breath, and he had refractory metabolic acidosis. Initially, we were scratching our heads what this is. He was in an ICU on a ventilator for almost 2 weeks. Miraculously, he came out. He had lactic acidosis caused by nucleoside reverse transcriptase inhibitors, which is a side effect which you don't see now. Again, the entire family rallied around. Somehow, miraculously, he came out. Now he's on one of those single pill regimens. He comes once a year. He's a very successful businessman, doting dad. His only son, who is uninfected, just now finished his master's in a European country. He is now pursuing a PhD. So wonderful stories. Second is another couple, again recently married. Wife becomes pregnant, antenatal checkup, she tests positive. He also turns out to be positive. And he becomes miserably ill. And his problem was chronic diarrhea, severe watery diarrhea, large volume diarrhea. He will end up in our ED in hypovolemic shock, kidney injury. Again, it was a cryptosporidiosis. Although they could not afford the ART themselves, the extended family chipped in. I think he was one of our first patients getting that Indinavir, the 20-pill regimen. But his disease was so advanced, even after starting ART, he will have this recurrent multiple admissions, same story, watery diarrhea, hypovolemic shock, kidney injury, admission, ICU, he goes back, comes back within short time. What amazed me was that wife's devotion, caregiver fatigue. She was never bitter, never complained about it. Not just the wife, the entire family chipped in. Even when she would call me, she will never identify by her name. She will say, I am so-and-so's wife. The devotion was something. And I think if this gentleman survives today, nobody else can take credit but that wife, the caregiver. We see these stories over and over again like that. So these two patients exemplify problems with that initial ART regimen, severe life-threatening side effects. Patients presented so late, even when we started ART, it took them a long time to come back to their baseline status. And once ART improved, both these patients have been following up with us for more than 20 years. Of course, they have developed diabetes and all other things, but they are doing extremely well from the point of view of HIV infection. I had a short stint in HICC. Hospital Infection Control Committee is headed by the medical superintendent. So the vice chair comes from microbiology and now ID. I was in charge of, from 2008 to 2013, I took over from Gagandeep Kang. Subsequently, George and Priscilla and Rajiv are heading now. Till then, we had maybe half a table in MS office for the HICC. Somebody doing the bond was the HICC medical officer. We changed all those things. Full-fledged dedicated office space inaugurated by the then director Sunil Chandi. We had a full-time medical officer, Hema, who started. We had dedicated HIC nurses. Earlier, all calls would come to the chair of the HICC. Now the nurses will handle 99% of the issues which arise regarding infection control. Very well-trained nurses, team of nurses. Antibiotic policy, the first antibiotic guideline was developed during Dr. M.K. Lalitha's former head of microbiology time. Now we have a very good antibiotic guidelines. Whether people use it is a different thing. How to use antibiotics rationally, recommendations on initial empiric treatment, targeted treatment, antibiotic, and hospital antibiogram, which is updated yearly. Very good document. Even if you look at the National Antibiotic Policy published in 2019 by ICMR, they have used our template. But unfortunately, I don't see people in our hospital using that much. We also started a surveillance program for hospital-associated infections. It was a mandate from accreditation bodies. Even then, we started active surveillance for high-risk infections in ICUs. So many innovations during my stint in HICC also. It was not all work, a lot of fun. I'll briefly talk about campus life. So these pictures, chapel view from the Big Bungalow lawns and the corridor next to the chapel, and Eden Garden, Alumni House, and I think this is Edward Galt Drive. Beautiful campus. When I came here in 1985, Vellore was brown and dusty, arid. So today it's so pleasant. You're literally living in a tropical paradise. Safe place to bring up children. Children were born here. Well, Deepak was born in Ernakulam. Nitin was born here. They went to school in SCADA school. Nitin did his MBBS and MS here. Deepak went on to Pilani and then got employed by Deloitte. So this is all of us, Nitin, Deepak, Tia, and both of us. And 5 years later, and latest addition to our family, 4.5-month-old bundle of joy, Ryan. Extended family, I was extremely fortunate. My brother Vinu and sister-in-law Suja also has been here. So nothing like family right next to you, living next to you, so we could get together. We always had pets, integral part of the family. On the extreme right is Tasha or Dashan. She passed away in 2016. And this is Lily. Lily was Nitin's cat in the men's hostel. She came home, lived with us. Unfortunately, this pack of wild dogs which roam around our campus, she was mauled once. We were successfully got her out of the clutches of the dogs, treated her. But second time, we could not rescue her. And this is Kit Kat. She adopted us during the COVID pandemic. She now owns the house, but she has permitted us to live there along with her. It is, like I said, it was not all work and no play. Amazing bunch of friends and friendship I have to talk about. So we had this wonderful friends, gracious friends who always threw open their homes for all of us to get together. This is a privilege and a blessing, especially during the period of lockdown. We got together quite often. There were wonderful conversations, lots of laughter, as you can see in these pictures. Everybody is laughing. We could talk about anything but work. So everything, books, movies, sports, politics. But we were talking about work was a no-no. So we'll discuss lots of lively, animated conversations. Bonding over shared meals. Food was plentiful. Brought out the culinary skills of people, bakers, barbecue, everything. We got together to celebrate important life events, birthdays, and other life events. We went on trips as groups. This is not the family trip, as the group. Ajanta and Ellora, the Muscat group. Sunil is there. Trip to the desert, Wahiba Sands. This trip to Kannur and Kasaragod was unique. It was food themed. So North Malabar cuisine is completely different from even somebody who grew up in Kerala and Central Kerala. So we had a wonderful time. Trip to Serengeti. Foster family, we were privileged. Principal's office allots foster children every year. Till we went on sabbatical and then the COVID pandemic happened, till that we were very regularly taking children. But we had adopted foster children, my classmates' kids, Sue's classmates' children, Deepak's classmates, Nitin's classmates, all became our foster children. Truly enriching. Still, most of them keep in touch. We know about where they are now, what they are doing, children, a wonderful experience. Finally, to teaching medicine. To be absolutely honest, I was a reluctant teacher in the beginning. Like I said, my father is a revered teacher. He was my teacher also when I was in college. His teaching methods was not just classroom teaching, a lot of actively involved in extracurricular teaching outside the classroom. Even today when I meet his students, they fondly tell me about how my father has influenced their career and life. So I had this really big shoes to fill. So a lot of trepidation. And like medical teachers of my generation, now medical technology, it's mandatory for everybody. If you want to get promoted, you have to attend the medical technology course. I had no formal training. So I don't know how I started teaching. But then once I started teaching, I learned to love it. What were my best moments? I tried to emulate my teachers. How the story about Dr. Brand telling about his student that you resemble my teacher. He said that, yeah, Dr. Brand, that's how you talk. So I think I ape Dr. Chandra and Dr. Dilip and all. So the best moments were empowering your students. Nothing brings you greater joy than your student doing well. On a personal side, selfish side, it sharpened my skills. I still remember you used to wake up early in the morning because you have to round with your very smart young postgraduate registrar. You have new patients admitted, so I have to be on my toes. So wake up every morning, read. It prevented burnout, again a selfish thing. Last but not least, the teacher's role as a change maker or a force multiplier. Ashita finished her MD. She did her MD from Ludhiana, and they went to Tezpur, Ashita and Deepak. And Tezpur, they have this seasonal fever outbreaks, massive numbers. They have run very busy inpatient and outpatient service. And fever season, hospital is flooded. And traditionally, it's treated as malaria. So she was desperate. Called the director. Director asked me, can you help? So we discussed, and I said, why don't you look for scrub typhus? That's when George had published extensively on scrub typhus. We were seeing scrub typhus every time, diagnosing and treating, and with very good results. And sure enough, most of those AFIs turned out to be scrub typhus. So Ashita was smart. She didn't stop her. She did CME for all the practitioners in the vicinity, approached the government, Joint Director of Health Services, stocked all the PHCs with doxycycline. So how the teacher's effect can multiply. Another one was about Subiraj, ICE batch of 87. Subiraj is a renowned bariatric surgeon, minimal access surgery specialist. I don't think I met him after he left after his MBBS and MS. His hospital, during the pandemic, no elective work. So everybody was recruited to do something about COVID. So he was put in charge of training the juniors about COVID. So he met me during the reunion and said, "Osi, I had no problem training these people in COVID-19. So my jaws fell. I used all your YouTube videos and slides." So that is when we had Anand's Pulse lecture and all those things. We had made those videos. It was uploaded on YouTube, so anybody could use that one. So a lot of people I have met have told me that how those videos were helpful in them to learn about COVID, manage patients, train others. Similarly, fellowship in HIV medicine. Even today, people across India, how training them have magnified the effects of a teacher. Of course, the best moment was in 2019, getting the Best Teacher Award. Finally, to the students, please understand there is no place like CMC. There's only one CMC. This is because of the unique combination of the learning environment here and the resources available. I don't have to enumerate them one by one. But please understand that this principle of being actively engaged, it takes two to tango. So a disinterested student is the bane of a teacher. So you have to be actively and passionately enlarged. A love of learning, commitment to lifelong learning is what sets apart a student of medicine. So please attend classes, attend clinics, don't cut clinics. It's not marrow and preplata which makes you a good doctor. It is spending time in the ward and learning from patients. Shampoo salesman, Dr. Verghese Kurian, the father of white revolution, the milkman of India. So he was called to give the graduation day address in Indian Institute of Management in Ahmedabad. This is in 1985. Apparently, Dr. Kurian was very short-tempered, and then he was very sarcastic about formal training and management and all those things. So in his address to this packed hall, graduates of IIM Ahmedabad, the foremost management institute in the country, faculty, everybody, parents, everybody sitting, he said that you are just glorified shampoo salesmen. So what he meant was that you get a degree from IIM Ahmedabad and you join a multinational corporation and you sell consumer goods. So when you leave CMC, what do you do with the training you get here? Don't be shampoo salesman, quote unquote. Be a change maker. Be not just a brand ambassador, brand evangelist. Make a difference in the patients, their families, the communities you serve. This painting, apparently the most painting of a doctor by Sir Luke Fields, 200-year-old painting. To me, maybe old-fashioned, but exemplifies a true doctor. Concerned doctor, in deep thought, by the side of a sick patient. So caring, considerate, concerned, by the bedside. So this is the ideal doctor. But today it has become like that. You sit in front of a computer screen, the patient is far away. So let's not, AI cannot replace a good doctor. All the advances in technology, I agree, most of it is for the good only. We are in much better terms. Life expectancy has improved. I don't say it's entirely because of medicine, maybe improved life standards. So let's not go this way. Finally, the magic of CMC. So 2021, Mr. Asim Premji delivering the Idas Kadar humanitarian oration. He talks about the magic of CMC, and there's a condensed version, 6-minute video of that. If you have not watched it, please do watch it. To me, the magic of CMC is two things. Ordinary people doing extraordinary things. This quote attributed to Dr. Arvindan Nair, it's a place which turns donkeys into racehorses. So that is the magic of CMC. And the second magic is going where others don't want to or fear to go. Numerous examples. Almost everything we do, leprosy care, community medicine, transplants, open heart surgery, HIV care, lots of things. You can go on and on and on. So I'll conclude there. So thank you very much to CMC. Thank you very much to the Department of Medicine. Thank you very much to the Department of Infectious Diseases. You have been very generous. CMC had a huge part in shaping me as a person, as a doctor, as a teacher. You cannot discount the influence of your teachers and teachers from college and school and Kottayam, and my parents and my family. But I owe CMC a great deal, immense gratitude. Thank you very much.
Thank you, sir, for that wonderful and inspiring lecture. We thank you for your dedicated service. I think you've been a great clinician, teacher, role model,